Give you a little overview. So Dr. Hashemi received her undergraduate degree from Vanderbilt and her medical degree from Brown University. She completed dry mouth, scleroderma. She completed her dermatology residency at here at MUSC and then followed up with specialized training in rheumatology, dermatology at Brigham's and Women's Hospital at Harvard Medical School. And she joins the faculty here at MUSC as a specialist in the diagnosis and management of, I'm not going to list all the things, but scleroderma is part of that, but other issues that, many of us have more than one thing going on. So she's touching on all these areas. You're going to find this a fascinating presentation and you're going to learn a lot and maybe appreciate, if you've not seen a dermatologist, why you might want to make them part of your team. So Dr. Hashemi, if you will join us.
Can everybody hear me okay? All right. Thank you so much for that really incredibly kind introduction. I'm really honored to be here. I was really honored to be asked to speak at this conference. And so today I'm going to be talking to you about scleroderma from a dermatologist perspective.
Not too loud.
I have no relevant financial disclosures. I will be discussing the off-label use of several different medications today. And while all patients in this talk have agreed to have their pictures shown, I do ask that we don't take any photographs of any of the patient images, just so that we can continue to protect their privacy. And lastly, I will discuss several studies in the literature that have been instrumental to our management of scleroderma, but I will make these all very easily digestible and very relevant. All right, so there are a wide array of systemic and cutaneous manifestations in scleroderma. Scleroderma can affect the heart, the lungs, the blood vessels, the muscles, the joints, the GI tract, the kidneys, and of course, the skin. And you will hear a lot today about the systemic manifestations of scleroderma. And so what I will be focusing on is the ways in which scleroderma affects the blood vessels and the skin and how we manage these problems. And so as a brief overview, we will be discussing skin tightening, Raynaud's phenomenon, digital ulcerations, sclerodactyly, telangiectasias, perioral furrowing and lip retraction, and microstomia. But before I dive into discussing specific cutaneous manifestations, I want to walk you through how a dermatologist might diagnose scleroderma. So this is a 52-year-old woman, and she presented to clinic with new onset Raynaud's phenomenon. Raynaud's is when the fingertips turn white and then blue and then red, and this most commonly occurs in response to a cold stimulus. She also has something called sclerodactyly, which refers to skin thickening and tightening on the fingers. Notice I'm really trying to pinch her skin there, but it's just too tight. I can't pinch it. And then she also has something called abnormal nail fold capillaries. Those are those red dots that you see next to the cuticle. She has a positive prayer sign. As the skin on the hands gets tighter and thicker, we can see joint contractures develop. And then patients have a challenging time completely opposing their hands and their fingers in a prayer. She also has telangiectasias there on the face and also on the palms. And so just based upon her exam, her skin exam alone, I know that this patient has scleroderma. In fact, Raynaud's phenomenon, abnormal nail fold capillaries, and sclerodactyly are the hallmark features. It's important to remember, though, that not all patients read the textbook. And so what do I mean by that? I mean that not all patients are going to present with such classic exam findings. Sometimes the first presenting complaint is just puffy fingers, and the patient has absolutely nothing else. And so we as dermatologists have to maintain a very high index of suspicion so that we can diagnose scleroderma early. And the reason that we want to diagnose scleroderma early is because systemic manifestations are relatively common. And so by diagnosing scleroderma early based upon our skin exam, we can screen for systemic manifestations earlier and hopefully detect any lung, heart, or kidney disease before any significant damage has been done. And what's interesting is that a very careful skin exam can actually help prognosticate which systemic features are more likely. So a patient with limited cutaneous systemic sclerosis, which is what you see on the left, these patients are more likely to have pulmonary arterial hypertension, and patients with diffuse cutaneous systemic sclerosis, which is what you see on the right, these patients are more likely to have interstitial lung disease. And so let's dive in. We'll talk more about skin tightening. This is a woman in her 30s, and she came to clinic with these puffy, shiny hands. You might notice that her skin on her hands also looks like it's a little bit tight. She also has new onset Raynaud's phenomenon. Here we see that she has a positive prayer sign. If you look closely, that skin tightening is extending all the way down to her wrists, and she has abnormal nail fold capillaries. And so we know this patient has scleroderma. Now, sometimes patients will present with skin tightening that's just limited to their hands, and that's it. But other times we can see skin tightening that occurs much more diffusely. So we can see it occurring on the chest, on the arms, on the legs. It can occur on the abdomen as well. And so how do we treat this? Because we both want to stop the progression, and we also want to reverse it as much as we possibly can. Well, historically, we've had really very little data on how best to treat the skin tightening associated with scleroderma. And what we did have was limited to very small studies like this one. So here there are 25 patients with new onset scleroderma. All of these patients are started on mycophenolate mofetil. Some of you might know that drug better by the name Cellcept, but it's the same medication. And what they found was that patients treated with mycophenolate mofetil had remarkable improvement in their skin tightening. But interestingly, that improvement was really slow. So most patients actually worsened over the first 6 months prior to seeing that improvement. Additionally, they took skin biopsies from patients prior to starting Cellcept, and then again later once they had been on Cellcept for some time. And what they found was that once patients had been on Cellcept for some time, those genes that cause skin tightening and fibrosis in the skin, well, those genes are markedly decreased on Cellcept. And additionally, importantly, patients treated with Cellcept had stabilization of their lung disease. And then in 2016, we get this study. Here, patients were treated with either mycophenolate mofetil or cyclophosphamide, and then we monitored their lung disease over time. And what we found was that both drugs actually work pretty well, but mycophenolate mofetil is just far better tolerated. And so based upon this study, the study we just talked about, and other studies like it, mycophenolate mofetil has really emerged as the go-to drug for both lung and skin disease. And so in my clinic, even if a patient does not have any lung disease at all, but they do have skin tightening, I am starting them on mycophenolate mofetil. And so let's meet this patient. This is a woman in her 40s, and you see she has sclerodactyly, abnormal nail fold capillaries. She has skin tightening on her face, also here on her chest. Notice how shiny that is. And she has something called salt and pepper dyspigmentation, and I'll talk more about that in just a little bit. The sclerosis extends all the way down to her abdomen. The skin on her arms is so tight that she cannot extend at her elbow or lift her arms up above her head. That's as far as she can lift them up. And so, of course, we start this patient on mycophenolate mofetil. And remember, we have to give it a while before we see any benefit. We really have to probably give it 6 months to a year. But when we give it that kind of time, we can see improvement like this. Notice the skin tightening on her chest has improved, that shininess is gone, and the dyspigmentation has remarkably improved as well. And then we see that prayer sign has improved. And now look, she's able to lift her arms all the way above her head and completely extend her arm at the elbow. If we look closer at her hands, we see I'm now able to pinch the skin on her hands, and she's better able to make a fist. And so I want to briefly discuss salt and pepper dyspigmentation. Salt and pepper dyspigmentation is what you see here, and you saw an example of it in the case I just talked about. It is a manifestation of scleroderma that predominantly affects Black patients, and it is one of the leading causes of body image dissatisfaction. You can imagine how much this dyspigmentation can affect someone's confidence and self-esteem. And historically, we've actually had very little data on how to treat this. Could we treat it? Could we reverse it? We didn't know. But then of March of 2022, which is not that long ago, it's 3 years ago, we get this study out of Brigham and Women's Hospital. The senior authors on this paper are Dr. Avery LaChance and Dr. Ruth Ann Flagels. They are my mentors. They trained me. I think they probably taught me everything I know about scleroderma. And in this study, they looked at mycophenolate mofetil for the improvement of salt and pepper dyspigmentation. And what they found is that mycophenolate mofetil is generally very effective, but it can take a really long time. So if you look at that image, the patient on the right, you'll notice that she was on mycophenolate mofetil for over 2 years prior to seeing that improvement in her salt and pepper dyspigmentation. And so let's talk about this patient. This is a 49-year-old woman, and she presented to clinic reporting worsening of her salt and pepper dyspigmentation. We see that there on her face, back, and chest. She also has some puffy fingers, but otherwise her exam is largely unremarkable. Now, she's already on mycophenolate mofetil 500 milligrams a day. So what are our next steps? What do we do? Can we help her? Can we improve that salt and pepper dyspigmentation? Well, we know she's on the right drug, but she's not on the right dose. So really, to see improvement in the salt and pepper dyspigmentation and the sclerosis associated with scleroderma, patients really need to be on the 3 grams a day dose. And so this is what she looks like after we increased her dose. Notice that before and after picture of her back and her face here as well. All right, one very important thing to keep in mind is that the last skin involved in scleroderma is going to be the first to improve on therapy. So this woman has regained complete mobility of her arm. But unfortunately, the first skin involved is going to be which is most often the hands, is going to be the last to improve, is going to take the longest, and it's not uncommon that we can't fully reverse it. And so what other options are available for patients with refractory skin disease? This is a study on rituximab. There were 54 patients in this study, and about half got placebo and half got rituximab. The graph on the left is a bit confusing, so let's walk through it. The y-axis is called the skin tightening score, and you actually want your skin tightening score to go down because that means that your skin is getting better. Okay. And so if we look at the blue line, which corresponds to the placebo, those skin tightening scores are going up. So that means that the skin is getting worse. And then if you look at the pink line corresponding to the rituximab group, those skin tightening scores are going down, meaning the skin is improving. And this is statistically significant, meaning that rituximab is generally very effective in improving the skin sclerosis or the skin tightening seen in scleroderma. Then we get this study on intravenous immunoglobulin, also called IVIG. And in this study, there were 30 patients whose skin disease was refractory to treatment. And so all of them get started on IVIG. Again, we see the y-axis refers to skin tightening scores. And so again, we want those skin tightening scores to go down. This corresponds to 0 months from IVIG initiation. So we can basically just think of that as the patient has not yet started IVIG. And so this is their baseline skin tightening score, okay? And on average, it's about 31. And then 12 months later, so 12 months of being on IVIG, the skin tightening score on average drops to about 21. And then at 2 years, it drops to about 14. And this is all statistically significant, meaning IVIG is very effective in treating refractory skin disease in scleroderma. And this is actually probably my go-to what to add on to mycophenolate mofetil. And so here's a case. This patient is on mycophenolate mofetil 3 grams a day for over a year. She still has a positive prayer sign, and you can see that she still can't quite make a full fist. She's ongoing sclerosis on her back. And so we start her on intravenous immunoglobulin or IVIG, and you see improvement in that prayer sign, improvement in in her ability to make a fist, and that sclerosis on the upper back has resolved as well. All right, what other options do we have when patients have refractory skin disease? JAK inhibitors are next. I figured that you would know them best by how they're advertised on TV. So this is how they're advertised. So Xeljanz is also called tofacitinib. Rinvoq is also called upadacitinib, and Olumiant is also called baricitinib. And there are actually many more JAK inhibitors than this. And so early on in scleroderma, JAK inhibitors were studied in the lab and in mouse models, which is what this study is here. And I don't really even fully understand all these pathways, to be quite honest. And so really what you need to know is that this study found that JAK inhibitors may lead to improvement in skin and lung disease in scleroderma. Fortunately, we now have multiple more studies on JAK inhibitors in scleroderma, and this one is in humans. It's a really nice systematic review. They identified 59 patients with scleroderma that were on a JAK inhibitor. About half of them had concomitant interstitial lung disease at the start of treatment. So 47 patients were on tofacitinib or Xeljanz, and 12 patients were on baricitinib, also called Olumiant. They were on treatment for about a year. And what they found was that 88% of patients, which is a lot of patients, that's a really remarkable results, had a remarkable improvement in their skin tightening. And among those with lung disease, there was no progression of lung disease in 28 out of 29 patients. There were no serious adverse events, and no patients had to stop treatment. And so overall, the data on the use of JAK inhibitors continues to evolve. And I truly hope that one day we will have enough evidence to support using these drugs in our patients with scleroderma, especially those with refractory skin disease. Shifting gears a little bit to talk about Raynaud's phenomenon and digital ulcerations. So Raynaud's is something that I commonly see in clinic. And I know we briefly discussed it a little bit earlier, but as a reminder, Raynaud's is characterized by episodic vasospasm or episodic clamping down of blood vessels. And this ultimately results in the fingers to turn white and then blue and then red. And this commonly occurs in response to a cold stimulus. Here's a really nice, beautiful example of Raynaud's. All the color changes are there: white, blue, red. Now, Raynaud's is considered a cardinal feature of scleroderma. It's thought to occur in 80 to 90% of patients, if not more. And I will tell you, when I was in Boston, Raynaud's was, I think, universal. I don't think I met one patient without Raynaud's. And many of the cases were quite severe. And I'm just going to warn you now that these are the cases I'm going to show you here today. In Charleston, I've seen a couple cases of severe Raynaud's, but not too many. I think it's probably because the climate here is just quite a bit warmer. And so it's really important to keep in mind that that episodic clamping down of blood vessels can lead to ischemia of the fingertips. And this ischemia can result in digital ulcerations, which is what we see here. Here's another example of a patient with severe Raynaud's, and you're seeing that digital ulcer develop on her fourth finger. Here's a really severe case. She's already lost some tissue at her fingertip. And so digital ulcerations can lead to numerous challenges. Infections can develop. These infections can extend deeper and affect the bone, and we call that osteomyelitis. That can require weeks of antibiotics. Sometimes patients need to be admitted to the hospital. And then, of course, these ulcers impact quality of life, your ability to perform just regular daily activities. This is a 10-year-old that I took care of in Boston, and you can imagine how much those digital ulcers affected her quality of life. And so it's very important to be very vigilant when these digital ulcers develop, because there are times when we consider these ulcerations a medical emergency. This is a woman who developed a very painful ulcer on her pinky finger. It quickly evolved into necrosis, and she needed a partial amputation of that pinky finger. So we do not want this to happen. We want to save the fingers. So over the next few minutes, I'm going to walk you through how we manage Raynaud's and digital ulcerations. To start, everybody gets behavioral modifications, okay? This includes keeping the core body temperature warm, wearing gloves and socks, minimizing caffeine intake, quitting smoking, and avoiding vasoconstrictors, which include nasal decongestants and beta blockers. Many of my patients in Boston told me about these. These are battery-operated, rechargeable mittens and socks, and you can get these on Amazon. Now, in patients who have digital ulcers, or when their Raynaud's starts affecting their quality of life, we move on to medical therapy. And so historically, calcium channel blockers have been considered first line, with nifedipine generally being preferred over amlodipine. But we've been increasingly using sildenafil or tadalafil first line, and then adding on a calcium channel blockers if symptoms are not adequately controlled. So if you don't know, sildenafil is also called Viagra, and tadalafil is called Cialis. And these were previously cost prohibitive, which is why we used to rely on calcium channel blockers first and reserve these only for severe cases. But now with online coupons such as GoodRx, these are relatively affordable. This is a study on sildenafil for digital ulcers and scleroderma. All patients were started on sildenafil, and what they found was that sildenafil led to significant improvement in pain associated with Raynaud's and also decreased the frequency of attacks. At the start of the study, there were 49 ulcers, and by the end, there were 17. I think the pictures really just show how effective sildenafil can be. On the left, you have before the patient started sildenafil, and on the right is after. Notice those ulcers have dramatically improved. And so let's meet a patient. This is a 34-year-old woman, and she has scleroderma and severe Raynaud's. She calls into clinic because she's having a lot of pain in that pointer finger. She's already on sildenafil. We've previously tried to put her on a calcium channel blocker as well, but she had swelling of her legs, and so she had to stop it. If you look at that pointer finger, you'll notice that the tip is purple. The other word I would use to describe it is dusky, and that is never a good sign. And she's also developing a little bit of ulcer at that fingertip, which you can see in the right image. So we don't want this to happen, right? So what can I do for her? Well, after sildenafil and calcium channel blockers, we typically move on to something called botulinum toxin injections. The other word for that is Botox injections. So Botox injections have been shown to be very effective in healing the digital ulcerations associated with Raynaud's. This is a study on Botox, and this is an image from that study. So the top row, photos A and C, correspond to before Botox, and the bottom row, B and D, correspond to after Botox. So let's first look at photo A and B. And you notice that the digital ulcerations on that pointer finger have dramatically improved after Botox injections. And then we compare photo C to D, and not all the ulcers have improved, but many of them have. And importantly, the pain has substantially improved as well. So how do I do Botox injections? Well, first, I don't. Okay. Hopefully this will work. So first I apply a topical numbing cream called lidocaine usually, and I let that sit for about 30 minutes. And then I come back and I'll clean off the hands. Here I'm using chlorhexidine. While the patient has the topical lidocaine on, I'll reconstitute the Botox. I usually need 100 units for both hands. And so I'll take 100 units of Botox and I'll reconstitute that with 2 cc's of just regular saline. Then I will come in at a 45-degree angle and I will inject Botox at the base of the finger. It's 5 units per injection. I will tell you, some of the patients think the topical lidocaine does absolutely nothing, truthfully. Others think like maybe it helps. I think it's probably mostly placebo, but I'm going relatively slow in this video for the purposes of the video. From start to stop of this procedure, it's probably less than a minute. So it's quick, but it's not comfortable and you should be aware of that. All right. Anytime I start a patient on Botox, I of course counsel them on the side effects and the potential insurance coverage issues. So side effects for Botox injections are incredibly rare, but they do include weakness, soreness, infection, and then patients of course have to be aware that it takes about 2 to 3 weeks for that Botox to fully kick in. Insurance coverage is a real issue here. This is a study that looked at insurance coverage for Botox for Raynaud's. If we look at the red box on the left, this corresponds to how often was Botox denied by the insurance company on the first attempt for the doctor to get it. Okay. In Medicare, it is denied 100% of the time. And in commercial insurance, it's denied 77% of the time. The second red box looks at, okay, how often can I get Botox approved if I appeal, peer-to-peer, appeal, etc. In Medicare, I can get it approved 0 times. And in commercial insurance, I can get it approved about half the time. So it is very challenging. All right, sometimes despite behavioral modifications, sildenafil or tadalafil, calcium channel blockers, and Botox, symptoms are still, they're better, but they're not adequately controlled. So what do we do next? Well, there are many medications we can add on here. These include something like alpha blockers, pentoxifylline, and even SSRIs. So an SSRI, an example is fluoxetine, and these are most commonly actually prescribed for anxiety and depression, but they have shown some benefit in Raynaud's as well. So what if everything fails, right? This is a woman who is getting monthly Botox injections. And to put that into perspective, that is a lot of Botox. I'm usually doing it every 3 months. She's also on sildenafil. She's also on a calcium channel blocker, and she's also on pentoxifylline, but she's developed this new ulcer. So what's next? Well, in refractory cases, we are often admitting patients to the hospital for something called epoprostenol. Epoprostenol is an intravenous medication, and it requires frequent monitoring in a hospital setting. We typically start at a very low rate and then increase to a maximum rate, and that maximum rate is held for about a week. And so that is oh.
For some reason, it just went away. Who knows?
All right, so this patient ended up getting admitted for epoprostenol, and we see that ulcer healing. And so to summarize this section, behavioral modifications and vasodilators are the mainstays of therapy. Sildenafil or tadalafil are effective for reducing the frequency and duration of Raynaud's attacks and also the pain. Botulinum toxin or Botox can be invaluable for recalcitrant disease, and hospital admission for epoprostenol should be considered to save threatened fingers. Shifting gears and talking about perioral furrowing and telangiectasias. So perioral furrowing refers to these deep vertical lines that occur around the mouth, and telangiectasias refer to broken blood vessels on the skin, and in scleroderma, we often call them squared off or mat-like. Both of these problems can really impact self-esteem, confidence, and so for the next few minutes, I'm going to talk to you about some of the cosmetic treatments that we have available. So first, perioral furrowing. These lines around the mouth are very deep, and so really the only treatment here is filler. It's very important to be aware that filler is not permanent. It takes multiple treatments to achieve the desired effect, and it will never be covered by your insurance. So it ends up usually being a couple $100s. But we do see great results. So this woman only had one round of filler, and we haven't completely erased the lines, but she's very happy here. She feels like it looks quite a bit better. This woman is bothered by the thinning of her lips. And again, here, really the treatment is filler. And so she had one round of filler, and you notice that the lips look a little bit plumper, but still very natural. This is a young woman who is very bothered by the prominent telangiectasias on her face. And unfortunately, there's no cream or pill that can erase these. Really, but we do know is that laser treatment here can be very, very effective. It's again important to be aware that it usually requires multiple treatments, and again, insurance will not cover this. The most common laser that we use is something called the pulse dye laser, and I just took this image off the web. And so if you get this procedure done, you'll have your eyes covered with opaque glasses. and then using the laser will try and destroy all of the broken blood vessels. It feels like a rubber band is being snapped against your skin. So the telangiectasias in scleroderma are thicker and more resistant to treatment than the telangiectasias in other diseases like rosacea, for example. And so what that means is that patients with scleroderma often need multiple treatments, and we have to use something called purpuric settings. So I have to use enough energy in the laser to cause bruising, which is what you see here. It's important to be aware of because this is what you'll look like after the procedure. The bruising will definitely fade. It takes about a week or two, but I just warn you of this because I don't want you to get it done before your child's wedding, for example. Okay. And so this young woman went through several rounds of pulse dye laser, and you see she had a really nice result. The telangiectasias are still there, but they have faded. And this is another woman who also had PDL laser or pulse dye laser, and her telangiectasias have almost essentially all gone away. Okay. In scleroderma, we can get fibrosis and scarring that occurs around the mouth, and this results in narrowing of the mouth opening, which is permanent, and we term this microstomia. Microstomia can cause difficulty eating, speaking, performing routine dental hygiene. Many of my patients with microstomia tell me I have difficulties opening my mouth. I have to avoid certain drinks. I have difficulties chewing. My dentist has difficulties taking care of my teeth. My lips are retracted. My mouth is dry. I must drink often. I can't eat what I want to eat. I have difficulties speaking clearly. The appearance of my face is modified, and I have trouble with the way my face looks. I want you to turn your attention here to the pie chart. This study asked patients with scleroderma what bothered them most. And here we see that the majority of patients reported that the facial changes associated with scleroderma bothered them more than the changes in their hands, their lungs, their kidneys. And so we know that microstomia has a profound impact on quality of life. It's not uncommon for me to see a patient that asks about treatment for microstomia. And so this is a 53-year-old woman who came into clinic to discuss microstomia. This is what she looked like on the day I met her. She's not substantially bothered by the perioral furrowing, but the microstomia is really significantly impacting her quality of life. So she sings in a band, and she's been having difficulty smiling, difficulty with vocal range, and also with just dental work. Her scleroderma is otherwise largely stable. So what options do we have for her? Bear with me here. I made this beautiful drawing, but my goal is to explain why the procedure I do for microstomia works. So here I am trying to depict normal tissue regeneration. So this is in someone that does not have scleroderma. That orange-yellow line you see is the outer layer of skin, also called the epidermis. The blue crisscross lines are what's underneath the skin. We call that the dermis or the extracellular matrix. There's actually a lot of substances in the extracellular matrix, and so I definitely simplified it here, but things like collagen are in the extracellular matrix. And one other major component is something called hyaluronic acid. And so I want you to imagine that all those blue lines are hyaluronic acid. Now, in normal tissue regeneration, we're constantly breaking down collagen, constantly breaking down hyaluronic acid and rebuilding it, break down, rebuild. And that allows our skin to stay supple and healthy. Now, the breakdown of hyaluronic acid absolutely necessitates something called hyaluronidase, which is what you see there in red, that red HA. And so in normal tissue regeneration, that's what you need. But then if we look at scleroderma skin, it was recently discovered, or at least relatively recently discovered, that there is a relative deficiency of hyaluronidase. And so that normal tissue regeneration can't happen. So hyaluronic acid can't really be broken down and rebuilt. And so because we can't readily break down hyaluronic acid, it's thought, or at least hypothesized, that at least can contribute to the skin tightening, the fibrosis, the scarring that we see in scleroderma. When us dermatologists found out that there is a relative deficiency of hyaluronidase, we thought to ourselves, interesting, because hyaluronidase is naturally made in the skin, but it is also a prescription medication. And so from that came the idea, I wonder if I inject hyaluronidase around the mouth, can I reverse some of that scarring and tightening? Well, there's actually 2 case reports in the literature showing the efficacy of hyaluronidase for improving microstomia. Those are before and after photos. Notice how remarkable those results are. My mentors at the Brigham then took this one step further, and they did a small cohort study. So in this study, there are 4 patients. And what they did was they did monthly hyaluronidase injections around the mouth, and each month they measured the mouth opening score. And you can see this in the graph on the right. The pictures on the left correspond to patient number 4, which is the dark blue line on the graph. And you can see that prior to starting hyaluronidase injections, her mouth opening score was 4.4 centimeters. After 2 injections, that mouth opening score improved to 5.9 centimeters. She then continued to have additional injections for several more months, and it improved to 6 centimeters. This patient corresponds to patient number 3, which is the orange line on the graph. And you can see that prior to starting hyaluronidase treatments, her mouth opening score was 4.5 centimeters. And then after 7 months of injections, it improved to 5 centimeters. Now, that's not a large numerical difference, but if you look at the photographs, look how much plumper her lips look, and that perioral furrowing has substantially decreased as well. She did not get filler, she did not get Botox, all she got was hyaluronidase injections. Also during this study, they asked patients about something called the mouth handicap score. So patients filled out a survey monthly that asked them to rate on a scale of never to always statements like, I have difficulties opening my mouth is dry, the appearance of my face is modified, I have trouble with the way my face looks. And prior to starting hyaluronidase injections, the majority of patients rate these problems as often or always. And then after being on hyaluronidase injections for some time, patients start to rate these problems as rarely, occasionally, and sometimes often. And so that's what's shown here. This is the mouth handicap score, and we see remarkable improvement in that score. Essentially, patients report symptomatic improvement with hyaluronidase injections. And so let's go back to this patient. Prior to starting hyaluronidase injections, her mouth opening score was 5.2 centimeters. And then after 8 treatments, it improved to 5.9 centimeters. She was very, very happy with these results, reported that she was better able to sing in her band, smile. Her dentist had an easier time, and she was, had a better time cleaning her teeth and just eating more of the foods that she wanted to eat. And look at that smile, so much bigger now as well. All right, I want to introduce you to this patient here. She's another patient that came to see me for microstomia. And the other thing that bothered her was these joint contractures in her hands. And that'll be important to know in just a minute. So we decided to do hyaluronidase injections, and her baseline score was 4.1 centimeter. After one treatment, it improved to 4.6 centimeters. After 2 treatments, it improved to 4.9 centimeters. And we're continuing to work together every month. And then notice how much bigger that smile has gotten as well. She says that she's now able to make duck lips, that she's having an easier time brushing her teeth, that she's been to the dentist since doing this, and the dentist is having a much easier time. And she's even eating more foods that she couldn't eat before. And so here's a nice selfie she sent me. All right, how do I do hyaluronidase for microstomia? First, I dilute 1 cc or 1 milliliter of hyaluronidase with 5 cc's of saline. I will sterilize the skin on the face. I have to perform nerve blocks. And then I inject in 2 rows around the mouth. This is where the nerve block goes. I'm going to show you a video of me doing this nerve block. If you are weary of needles, I would look away, okay? But I just want you to know that if you choose to do this, like this is what you're getting into, okay? So this is the infraorbital nerve block, okay? I do need to go next to the nose. I have to inject deep to get that infraorbital nerve. I have to inject about 1.5 milliliters of lidocaine here. It's not comfortable, okay? And I have to do this on both sides of the face. Okay, this is the mental nerve block. It's actually a little bit easier. I have to block that nerve that comes there. All right, now I'm going to inject around the mouth in a row of 2. Now, the reason I do this nerve block is because now the patient will feel absolutely nothing. And there are multiple little injections that I have to do, and the hyaluronidase itself also burns. So it's important to numb. And so this is the video. So I'll go all the way around the mouth, injecting 6 milliliters total, which is a mixture of 1 milliliter of hyaluronidase and 5 milliliters of normal saline. I'm sorry. Once a month for 7 to 8 months. All right. Of course, anytime I do hyaluronidase injections, I counsel on side effects and insurance coverage issues. The side effects are real, so you will have numbing of your entire face for about 4 to 5 hours. Bruising is common, it lasts for a few days. Allergic reaction I've never seen before. It's very, very rare, but it's theoretically possible to have an allergy to the hyaluronidase. And then unlike Botox, insurance is actually not a challenge here. So it's relatively easy for me to get it covered. And if it's not covered, it's about $40 out of pocket. All right, this is our last section of the day. Here we're going to talk about sclerodactyly. So we know that the skin on the hands gets thicker and tighter, and this can lead to joint contractures, and it's thought that these joint contractures are permanent. Let's go back to my patient. If you remember, the 2 things that bothered her are the microstomia and the joint contractures in her hands. And so after knowing each other for about 2 months, she comes into my clinic and she says, hey, if you can inject that stuff around my mouth and get this to happen, can you inject it into my hands? And I said, funny you should ask. I want to introduce you to Dr. Avery LaChance. She is a dermatologist at Brigham and Women's Hospital, and she's one of my mentors. She's been talking about doing hyaluronidase for sclerodactyly for a couple of years now, but the procedure has never been done before. And part of the reason it's never been done is because we don't fully understand, or we didn't fully understand the risks of the procedure. So what harm could come from injecting hyaluronidase into the hands? Now I want to introduce you to Dr. Simon Talbot. He's a plastic surgeon at Brigham and Women's Hospital, and he works very closely with the derm room team there. He's the go-to guy for excising calcinosis and other surgically related problems with our connective tissue disease patients. And that's me. And so one day we all met on Zoom. Okay. It was 8 p.m. on February 5th. And the reason I tell you that is because I just want to highlight that it really wasn't that long ago, only about 6 weeks ago. And the purpose of this talk was to ask Dr. Simon Talbot his opinion on the procedure and to better understand from a surgeon's perspective the potential risks and benefits of injecting hyaluronidase into the hands. And what came out of this talk is essentially, there is probably very, very little risk to the procedure, and it's probably worth trying, but there are some very important things that we need to keep in mind. First, patients with severe joint contractures probably won't see much benefit. When a patient has a joint contracture, their joints have been locked in a position for years, sometimes decades. And when that happens, the muscles and the tendons have also been contracted, and that leads to shortening of the muscles and the tendons. And so even if I inject hyaluronidase into the fingers and I completely loosen up all of the skin on the fingers, I cannot undo any of the damage that has already been done to the joints, tendons, and muscles. So even if I completely loosen up all the skin, that underlying damage may prevent any movement. His point was essentially patient selection likely really matters here. And we'll get to that more in just a minute. His other point was that the blood vessels in scleroderma are already really fragile, and so you want to avoid damaging them. This is the anatomy of the hand, and we see that the blood vessels run along the sides of the finger. And so I said, okay, I won't inject there. I'll inject on the dorsal and palmar aspects of the finger. His other point was that you have to be very careful about the amount of volume you use. You want to avoid injecting so much volume that all that pressure builds up and compresses the blood vessels and prevents any blood from getting to the fingers. That's not a good thing. In someone without scleroderma, I can pretty easily and safely inject anything from 5 milliliters to 6 milliliters per finger. But in scleroderma, that volume is probably substantially less. And then I also have to keep in mind that I have to numb the finger using lidocaine. And so I ultimately think to myself, okay, I'm going to probably need about 1 milliliter of lidocaine here and 1 milliliter of lidocaine here. So that's 2 milliliters. And then to keep volume down, I'm going to use 1 milliliter of hyaluronidase and dilute that with 1 milliliter of saline. And then also just to make myself feel substantially better, after injecting lidocaine, I waited 30 minutes prior to doing the procedure in the hopes that all that volume would diffuse. And so I had a very long talk with my patient about this procedure, the risks, the benefits, and that there was never any way that I would be able to make her hand go from what's on the left to what's on the right. It's just not possible. But I'm hoping that I could potentially help her get a little bit more mobility, a little bit more movement. And so we ultimately decided to do the procedure. We chose the pinky finger because this procedure has never been done, and we think we know the risks and benefits, but again, the procedure's never been done. And this pinky finger really just gets in her way. So if any unforeseen side effect happened, it wasn't going to impact her life in any significant way. This is what her pinky finger looks like before the injection. You notice it's contracted down. And then on the right there, I am trying really hard to lift it up. Okay. And this is a video. So here I'm really trying to move it. I'm actually pulling pretty hard here. All right, this is the day of the procedure. Take my lidocaine, I inject 1 milliliter here and 1 milliliter here, and then I wait some time, let it diffuse. And then I take my 1 milliliter of hyaluronidase and 1 milliliter of saline, and I inject all here, here, and I try and get some here, and I try and get some here, but it proves to be a little bit more challenging than I thought it would just because of how contracted the finger is. And then I see her back 2 weeks later. So this is earlier than I probably would have otherwise. I usually would have given it 4 weeks, just to how we do with microstomia as well. But if you remember, I'm also doing hyaluronidase for her mouth as well. All right, this is the before and after, 2 weeks later. So, we haven't straightened out her finger, of course, but she does have more movement. So I'm much easier able to lift that finger up. And then here, is side by side, I'm having a much easier time getting my finger underneath her finger. And so this is after 1 round. And so we will continue to do 7 to 8 rounds and see what kind of benefit we get. And this is a video. So again, this is before hyaluronidase, really trying to lift her finger up here. And this is after. All right. A couple weeks later, she comes back and we have a chat about your pinky finger's so contracted. I'm just not quite sure how much benefit we're going to get from it. And so we decide to do a finger that she has more mobility in, that is not quite as contracted. And so we do her pointer finger. All right, this is the before. She can almost touch her thumb with her finger. All right, we do hyaluronidase injections, and this is 2 weeks later. Okay. I don't have a video of it because I tried, but I couldn't characterize it quite well. She's also better able to fully extend her finger as well. Again, this is only after 1 round. So we've now started hand occupational therapy as well in the hopes that we can get even more benefit. All right, for the future. I think choosing the right patient for this procedure is likely going to be very important. And I think that patient is going to likely be someone that has predominantly just puffy fingers and someone that does not yet have any joint contractures or maybe has very mild joint contractures, with the goal being that this procedure could hopefully prevent those joint contractures from happening. Also, I do suspect that we will likely, at some point in the future, have a multi-institutional prospective study just to really evaluate, is this procedure effective and is it safe? And with that, thank you so much. I will take any questions.